This third lecture of BNV review. So response to exercise, initiator, muscle hypoxia, mediator, sympathetic nervous system. Vasodilation occurs from adenosine, lactate, carbamazepine, potassium, lowers TPR, then sympathetic nervous system activated, increased cardiac output, so increased stroke volume. Primary determinant for systolic BP is stroke volume. It is stroke volume, okay? Systolic BP rises. Primary determinant of diastolic BP is TPR. Diastolic BP decreases slightly or stays normal. Pulse pressure increases. TPR decreases. And this is the MCQs of UWorld. Coronary arteries are perfused during diastole. Preload increases with exercise. Left ventricular ejection fraction increases. Lusitropy, myocardial relaxation, also increases with exercise, just like contractility. Key regulatory protein for lusitropy is phospholamine. So exercise begins muscle hypoxia, vasodilation, TPR will be decreased, or after load will be decreased. That will decrease our normal diastolic BP. Then sympathetic activation, heart contractility increase, heart rate increase, lusitropy increase. So increased, that will decrease, and systolic volume, that will increase ejection fraction. Heart rate is increased, cardiac output increased, that will lead to increase in systolic BP. Increased lusitropy, that will increase preload and diastolic volume. Sympathetic activation on peripheral vessel, arteriolar constriction, venous constriction, so increase preload and diastolic volume. Lecture number 4, blood flow mechanics. Change in pressure, that is equal to cardiac output times TPR. With constant cardiac output, del P is directly related to TPR. Flow equals velocity times area. Compliance is distensibility of vessel. Resistance is inversely related to compliance. Older patients and hypertensive patients increase pulse pressure because of low compliance. Then we have compliance is inversely related to pulse pressure. Compliance equals change in volume by pulse pressure. Pulse pressure okay. Pulse pressure equals change in volume by compliance. In old age, patients have stiff vessel, less compliant, high pulse pressure, R is 170 by 100. For example, arterioles are considered as resistant vessels. Major determinant of TPR, large pressure drop, low viscosity condition, for example, anemia, high viscosity condition, polycythemia, multiple myeloma, and spherocytosis. And we have Poiseuille's law. Resistance is directly related to viscosity times length, inversely related to radius power 4 times. Human organs are arranged in parallel. Del P for body, arterial pressure minus right atrial pressure. Del P for lungs, pulmonary artery pressure minus left atrial pressure. TPR by systemic vascular resistance for body. Peripheral vascular resistance for lungs. MAP for body 93 mm of Hg, that is mean arterial pressure. MAP for lungs 27 mm of Hg. For total body, TPR equals MAP minus right atrial pressure by cardiac output. For lungs, pulmonary vascular resistance equals pulmonary arterial pressure minus left atrial pressure by cardiac output. Flow, that is equal to cardiac output, which is equal to area times velocity. Area investigation related to velocity. Lav Laplace tension on ventricle is directly related to pressure in ventricle times radius of ventricle by thickness. Then we have pressure overload occur in case of chronic HTN and aortic stenosis. Volume overload occur in case of aortic and mitral regurgitation. Hypertrophy, that will lead to decrease wall tension occurs with chronic pressure and volume overload. Eccentric hypertrophy, sarcomere aided in series, volume overload of left ventricle, like mitral and aortic regurgitation. That's also found in cardiomyopathy with a reduced ejection fraction, that is in ischemic and non-ischemic. Left ventricular mass increase, uh, but no increase in wall thickness. Concentric hypertrophy, pressure overload, sarcomeres aided in parallel, seen in chronic hypertension, in aortic stenosis, also with diastolic heart failure. Flow for lungs and body, cardiac output, resistance, pulmonary vascular resistance, total peripheral resistance, start pressure, pulmonary arterial pressure, and aortic pressure for body. End pressure for lung, that is left atrial pressure. For body, that is right atrial pressure. Change in pressure, that is for lungs, pulmonary arterial pressure minus left atrial pressure. For body, aortic pressure minus right atrial pressure. Then the area is highest for capillaries but lowest for large arteries. Velocity highest for large arteries but lowest for capillaries. Resistance highest for arterioles but lowest for veins. Change in pressure highest in arterioles but lowest in veins. Okay, then for lecture 5, regulation of BP. Baroreceptors found in aortic arch and carotid sinus show rapid response, while in kidneys show slow response. Aortic arch through cranial nerve 10, that is vagus nerve. They will reach their message to the nucleus of tractus solitarius. Baroreceptors only detect high BP, that is for aortic arch. For carotid sinus through cranial nerve 9, that is glossopharyngeal nerve. They will reach their message through that nerve to nucleus of tractus solitarius. Baroreceptors sense both low and high BP and are most important. Okay, we talked about this nucleus of tractus solitarius in medulla. In case of high BP, arteriovenodilation plus decrease in heart rate plus contractility. So these are various regulatory methods, right? In low BP, for example, in hemorrhage, opposite will occur. So arterioveno constriction, heart rate will be increased, contractility will be increased. Carotid massage, carotid massage will lead to syncope while shaving or buttoning shirt. In carotid occlusion, severing cranial nerve 9 during surgery, that will lead to opposite of carotid massage. So BP will rise. Severing of cranial nerve 10 has not that much good effect on this response because does not sense low BP very well. Coronary blood flow increases during diastole. opposite to other vessels. Subendocardium receives less blood supply, more vulnerable to ischemia. Heart regulation maintain constant blood flow. Edema, systemic capillaries leakage and will lead to lower extremity edema. Increase hydrostatic pressure that is found in case of edema in that will lead to edema in heart failure. Decrease plasma proteins, nephrotic syndrome, or liver failure. Increase capillary permeability in case of toxins, infection, and burn. Increase interstitial osmotic pressure, lymphatic blockage. First space, intracellular fluid, two-thirds of body fluid. Second space, extracellular fluid, one-third of body fluid. Third space, normally fluid shouldn't be there. Pleural effusion, ascites, cerebral edema, low intravascular volume or high total volume, found in post-op and sepsis also. So, lung, 100% of cardiac output that is received by lung. Liver, largest systemic blood flow is passing through that. Kidneys, highest blood flow by weight. By weight, this is important. Heart, largest oxygen change, 80% it is taking, right? So that will increase if it needs more oxygen, then what is the best mechanism is to increase demand, that is vasodilation. Heart, key control variables, carbon dioxide, adenosine, nitric oxide or nitrous oxide. Okay, brain, carbon dioxide, pH. Kidneys, BP and sodium chloride feedback. Lungs, hypoxia, vasoconstriction. Skeletal muscle, lactate, adenosine, potassium. Skin, sympathetic stimulation. Kidney, brain, heart, excellent auto regulation systems. Skin, poor autoregulatory capacity.